All right. Thank you for being with us, Jen. We're just going to get right to our questions. I think we have a lot to learn from you. So we'll start pretty broad. How do you define HFpEF?
So, how to define HFpEF still remains quite challenging. There's no single gold standard diagnostic test that really tells us whether or not somebody has HFpEF. And so, various definitions have been used across different guidelines, clinical trials, outcome based studies. So, this is a little bit all over the place. Most recently, the universal definition of heart failure has been adopted, and that really defines HFpEF as the presence of the clinical syndrome of heart failure that's caused by structural or functional cardiac abnormalities with an LV ejection fraction greater or equal to 50%. And what we want to see is that this is corroborated by some objective evidence, either the presence of elevated natriuretic peptides or other evidence of congestion.
Okay. So it sounds a little bit more nuanced than if I just have a patient who clinically looks volume overloaded and their EF is greater than 50%. I can't just automatically label that patient as HFpEF. So how would you approach a patient like that?
That's a great question. So I would say if you have somebody who has the clinical syndrome of heart failure, their jugular venous pressure is elevated, they're short of breath when they walk around, and you do an echo and their EF is greater or equal to 50%, I would still label that as HFpEF. Now, something that comes up a lot in terms of diagnostic workup is that there are things that can look like HFpEF that we call HFpEF masqueraders that can cause heart failure with normal ejection fraction. And so it's really important to try to identify and differentiate HFpEF masqueraders from what I call garden variety HFpEF because the management is often really different. So, for example, people with restrictive cardiomyopathy can present with heart failure and a preserved ejection fraction. Of course, we know that there it's important for us to, for example, evaluate for amyloid and other causes when the clinical suspicion is high. And the treatment would be really different from this sort of garden variety HFpEF.
So it sounds like amyloid is one of these HFpEF masqueraders. Would you be able to walk us through some of these other HFpEF masqueraders?
Yeah, absolutely. This is sort of where I think some of our clinical intuition can really be so helpful. Some tip offs that there may be a HFpEF masqueraders really come with your careful clinical exam and history. So, for example, if you find on physical exam someone has a Kussmaul's sign, which is an indicator of decreased RV compliance, I would say that's really not typical of garden variety HFpEF and should prompt further evaluation for something that's involving the RV in addition to the LV. And so broadly, I guess, how can we think of HFpEF masqueraders? I think of them as several different buckets. So there are people who have some other primary cardiomyopathy. That could be a restrictive cardiomyopathy or hypertrophic cardiomyopathy. There are people who can present with high output heart failure in the setting of some systemic disease like anemia, hyperthyroidism, cirrhosis. And then there are people that have some primary other cardiac abnormality that can cause them to present in heart failure, including valvular heart disease, coronary disease, or even pericardial disease. So those are sort of broadly the HFpEF masqueraders that I typically think about.
Okay, that was very helpful to walk through. I'll change gears a little bit, but in the hospital or as we're learning about HFpEF, we really frequently hear the term diastolic dysfunction tied to the term HFpEF. Is HFpEF defined by diastolic dysfunction?
That's a great question. So I think of diastolic dysfunction as something that happens when your left ventricle is stiff. And that can happen in a lot of different circumstances and doesn't necessarily equate to someone having HFpEF. It is an important component of HFpEF, but other people can have diastolic dysfunction. For example, invariably, people who present with HFrEF or reduced ejection fraction heart failure or systolic heart failure also have some component of diastolic dysfunction concomitant with that. So the two are related, but not exactly the same.
So it sounds like people with HFpEF have diastolic dysfunction, but you can have diastolic dysfunction without having HFpEF.
That's exactly right.
I think this is going to be like a good myth busting for people because I remember a time at NYU, this was like maybe 6 years ago, almost everyone's echo would say some diastolic dysfunction 1 to whatever grade. And then everyone's one-liner, then added heart failure preserved ejection fraction. And do you have some like helpful pointers? Sorry, I have two questions. Do you have some helpful pointers of how to understand this echo? Yeah, I'll start with that and then I have a follow-up question.
Yeah, that's such a great question. So I always go back to the physiologic definition of heart failure, which is the inability of the heart to meet the metabolic demands of the body or to do so at the expense of elevated filling pressures. That's sort of the classic Eugene Brownwell definition. And so it's a clinical syndrome at the heart of it. So if you just have an imaging finding of diastolic dysfunction, but the person doesn't have any symptoms of heart failure, can exercise, run 5 miles, that is not HFpEF by definition, right? You have to have the clinical syndrome. Now, invariably, diastolic dysfunction is an important component. We know patients with heart failure with preserved ejection fraction have LV stiffness as a big problem that really makes them exercise intolerant. And so this is a really complex issue. I would look at them as sort of slightly overlapping Venn diagrams. There are people that have both, but having diastolic dysfunction does not mean you have HFpEF automatically in the absence of the.
Do you look at left atrial dilatation to then be like, this stiffness is so much that we've now dilated your LA? And then I'm thinking about all the patients in the hospital who are like, bed bound, this person keeps falling, who I just saw yesterday, and they're like had a back surgery, is deconditioned. Like, it's not as clear what's going on with the JVP, with the level of obesity, all of the above. And so, yeah, is there any other things that we can use? Do you look at the LEDs or anything else from that echo?
That is such a fantastic question. And part of the reason why HFpEF diagnosis is so challenging. I wish there were a single echo measure that could tell you, yes, this person has HFpEF, and there isn't. But of course, we know structural and functional remodeling does happen in HFpEF and are important components that we do look for by echo. What does that actually mean? It means left atrial dilation, like you said, and often we think of left atrial dysfunction actually as part of HFpEF presentation. Some people have actually looked at left atrial mechanics and how the left atrium is actually contracting and relaxing as well. And then the other echocardiographic parameters we often look at is some measure of diastolic function, and that usually entails looking at how the left ventricle is filling. We can get some sense from measures like tissue Doppler velocities of the myocardium. So we're looking at myocardial relaxation. Often what we're focused on is the mitral annular E prime velocity, which is essentially how quickly your left ventricle can relax at the beginning of diastole. And then the other measures that go along with HFpEF are left ventricular hypertrophy. So those are sort of the classic things that we look for. More recently, people have also started incorporating something called global longitudinal strain, which is essentially a measure of myocardial deformation as sort of an early sign that can be abnormal in patients with HFpEF as well. So when we get into things like some of the newer HFpEF diagnostic risk scores, those have incorporated all of those metrics: left atrial size, left ventricular hypertrophy, left ventricular diastolic function, and global longitudinal strain as imaging markers that we can get some better sense of in terms of HFpEF risk.
That was really helpful for all the echo findings. Shreya, did you have follow-ups on that, or am I good?
I did. Do you have any like cases, just because I think that's such a valuable teaching to like compare and contrast, like this patient I had, it was a little tricky, but it was this that helped me kind of think about this person in the diagnosis. And then are there any, if they're not, no worries, we can move on. All good.
Sorry,
Maybe it'll
I'm
come.
not sure, like,
Maybe it'll come
specific
as more
example comes
questions,
into
more
mind.
questions
Yeah.
arise. Just because I find it helpful. Where, yeah, go for it.
Actually, the other point to keep in mind with echo is it can be helpful when it's abnormal. However, some people with HFpEF can actually have normal echoes as well. So that's what makes it really, really tricky. In fact, when you look, there was a trial called PARAGON-HF, which looked at ARNI versus ARB in patients with HFpEF. And the echocardiographic substudy looked at a bunch of patients who were enrolled with known HFpEF, and up to a third had normal echoes, meaning they didn't have evidence of left atrial enlargement or left ventricular hypertrophy. And so you can see that, again, echo is not a gold standard diagnostic test for HFpEF. Some people, for all intents and purposes, can have normal looking echoes and still have the clinical syndrome of HFpEF. So that's, I think, another challenge in this field.
I feel like that's such a big, that's like mind-blowing thing number 2, because what? Now I'm just so maybe if someone has, I don't know if you remember a patient that met that criteria for you, but maybe they had gained weight, some lower extremity swelling, and their BNP was a little elevated. No, but can you have an elevated BNP if there's no stretching of the heart, if the echo is normal?
There are various different reasons why you can have an elevated natriuretic peptide level. The most typical reason is with cardiac stretch, and so that's what makes it such a good marker of heart failure. So we know that, of course, in patients presenting with dyspnea and suspected heart failure, natriuretic peptides are sort of the central test that we send to try to verify whether or not they have heart failure. I think certainly in the setting of chronic kidney disease, in the setting of atrial fibrillation, your natriuretic peptide levels can often be more elevated than what we would typically see in just volume overload states. Women typically have higher natriuretic peptide levels compared with men in general. So I think that's so fascinating. We don't really know why. And then I guess the flip side, similar to echo, a normal natriuretic peptide level, unfortunately, is not awesome at ruling out HFpEF. We know there are patients who have natriuretic peptide deficiency, we call it. They can often have very low natriuretic peptide levels despite being very volume overloaded. In some studies, we think this is tied to having obesity. Some of it might be related to insulin resistance as well. And we know there are natriuretic peptide gene variants that can often affect your sort of inherent, your natural levels of natriuretic peptides and cause some variation between individuals, even in healthy states. So all of those reasons are potential etiologies for natriuretic peptide deficiency. And so when you see a normal BNP in someone presenting with true clinical heart failure, they still have true clinical heart failure. BNP in that setting doesn't rule it out, of course.
So to hone in on that group of people, somebody who comes in with very clinical heart failure, their BNP is normal, they fall into that 30% that you mentioned that has a totally normal echo. What other diagnostics would you turn to at that point?
That's a great question. I would say that the diagnostic workup in somebody who comes in, they have the clinical syndrome of heart failure, and yet you don't see echo abnormalities and their natriuretic peptide levels are normal. I would say, again, you're faced with this question. They have HFpEF. Is this a HFpEF masquerader or is it sort of garden variety HFpEF? And so I would really be careful and make sure that we thought about other contributors. Do they have some suggestion on their echo of potentially constriction or valvular abnormalities? Is there RV involvement? Are there other tip-offs that we may need to sort of go searching? It's really individualized. And so I would say you should think about coronary disease. You should think about infiltrative disease. You should think about potentially high output heart failure and other things that might be contributing. And then depending on what the likelihood of each of these other HFpEF masqueraders is, sort of pursue further diagnostic testing in that setting. Otherwise, if you've ruled that out, I would go ahead and sort of label or classify this person as having garden variety HFpEF because they have the clinical syndrome of heart failure. And I think in that setting, it's very reasonable to start pursuing treatment for HFpEF as you would in somebody who has, meets the other criteria, high BNP, et cetera.
Okay. So to kind of recap there, it sounds like if somebody comes in with a clinical picture of heart failure, even if they have a normal echo, normal BNP, you rule out these HFpEF masqueraders. And at that point, there's not a certain diagnostic that you need to pursue to confirm this diagnosis. We clinically begin to treat this patient as a HFpEF patient.
Yes. I think if you have evidence of congestive heart failure on your exam and you have symptoms, then I would go ahead and treat them as such. There are cases that are challenging where the diagnosis is still not clear. You're not really sure where the JVP is. It's hard to see. And in that setting, if the diagnosis is still not clear, I do think sometimes turn to what I call advanced testing. And that can involve invasive hemodynamic testing. So we can do, for example, a right heart catheterization to assure that what we think is the JBP on exam is actually evidence of elevated filling pressures in somebody. And so that might be really helpful to confirm your diagnosis in cases when you're still not sure and the exam maybe is not so clear. So I find that in those cases, advanced testing might be helpful. The other category of tests is if volume status is unclear on exam, sometimes I consider some provocative maneuver. It turns out that some patients with HFpEF at rest may have normal pulmonary capillary wedge pressure, but yet they get incredibly dyspneic walking from your clinic office to the parking lot. And those are individuals whose primary presentation really is dyspnea, right, or exercise intolerance. And it turns out that there are people who have normal filling pressures, but with exercise, they have this really exorbitant rise in their pulmonary capillary wedge pressure that really is the cause of their dyspnea. And so in those cases, really thinking about some tests that can unmask this abnormal physiology is something that I feel like is something really important to consider. How do we unmask it? Well, I think the probably most physiologic test would be to have them exercise just to see what happens. And then we can assess their cardiac response either with an echo, or sometimes we actually do what we call a level 3 CPET, where we have somebody insert a pulmonary artery catheter and we have the patient exercise with a pulmonary artery catheter in place so we can actually monitor their intracardiac filling pressures as they exercise. The other provocative maneuvers that have been sort of studied in that setting are either passive leg raise. So it turns out that even with passive leg raise and increasing your venous return, sometimes you can sort of provoke an abnormal response. And then the other potential maneuver to consider is volume challenge. So you can give them some IV fluid and sort of see, do they have, again, this like very exorbitant rise in LV filling pressures that indicates LV stiffness, if you will.
All right. So that was really helpful to understand the role of exercise, stress echo, and a lot of those provocative maneuvers. From some of my reading, I also read about cardiac MRI, and I'm wondering, based off of what you've already told us, is that more of something that's used to rule out those masqueraders as opposed to something that helps us actually rule in HFpEF?
That's correct. I think of cardiac MRI as really useful if you are wondering about a potential primary cardiomyopathy, and it can be really helpful in trying to point at potential infiltrative disease. And so I really think of cardiac MRI as a tool to further suss out, is this a HFpEF masquerader, and what potential etiology might be underlying their cardiomyopathy.
On that note, can we just get a soundbite of like, why is it important to understand if it's a masquerader or not? And maybe you can go through the specifics, and because you're like, I can see someone being like, whatever, it's the same. They get diuresis, they feel better. Okay, cool. But just to like close that loop of why it would be important to think through that.
Absolutely. So why is it important to consider HFpEF masqueraders? I think we have more and more evolving therapies for specific conditions that fall under this grab basket of HFpEF masqueraders. So for example, we know people with cardiac amyloidosis may benefit from medications that prevent further amyloid deposition and may actually sort of change the trajectory of their disease process. And so that would be important, of course, to kind of figure out because the therapy is really, really different. Similarly, if somebody has HFpEF in the setting of severe aortic stenosis, well, of course, we know that we should really focus on whether we can address the valvulopathy as the underlying cause and then potentially really change their clinical trajectory on that basis. So I think the idea of really going after HFpEF masqueraders is we want to identify potentially treatable conditions that might be treated very differently from garden variety HFpEF, and sort of this concept of guideline-directed medical therapy or GDMT.
Okay. I promise one very small question and then Rathi, move us. Just like the severe AS leading to the HFpEF masquerader. Can you just give us some objective things that we can look at in the echo? You're like that where you think, oh, it's this AS that's causing it versus this person's hypertension. Probably is like concomitant, but like how severe or how bad does AS need to be for one to invoke that versus like, oh, there's other things going on.
Oh, that's a great question. I think generally, if someone has moderate or greater aortic stenosis, I typically think that's hemodynamically probably significant enough to potentially lead to symptoms. And so in that case, we would for sure be sort of monitoring over time. And when appropriate, with severe aortic stenosis or increasing symptoms, we may want to intervene on that valve earlier rather than later. But you bring up potentially a really interesting point, and that is that HFpEF is a disease of multimorbidity. And so often it's really hard to completely attribute someone's symptoms to one single cause alone, right? Often we see patients who have obesity plus HFpEF plus COPD plus diabetes and hypertension and maybe some valvular component to this as well. And I think it's really challenging and often impossible to kind of pinpoint your finger as to one etiology that's going to fix all of their symptoms. And so that often I feel like has to be navigated in a very individualized way. And you try to address as many things as possible and see if the patient feels better with whatever interventions you're doing. But that can be often really tricky.
Yeah, that's really interesting. The way that you said that one line, it's like the most classic one-liner that we see in patients in the hospital, like hypertension, diabetes, COPD, and HFpEF. And HFpEF is one of those things that I've gotten used to just seeing in so many one-liners. So I'm still trying to understand because I'm newer here too to medicine, is it looks like there has been this increasing diagnosis or prevalence of HFpEF that it's thrown into so many one-liners. Do you think do you have any intel or any, I don't know, any commentary on why are we seeing HFpEF in everybody's one-liner? And do you think this is actually an increased prevalence and diagnosis of it, or is it a mistake?
Yeah, that's a great question. So there are probably several different components to this. I think fundamentally, both the incidence and the prevalence of HFpEF is increasing. And we don't know for sure why. I suspect it's because of the growing obesity epidemic and all of the downstream consequences of that. And we know that obesity and associated metabolic dysfunction are major contributors to HFpEF risk. So I think that's part of it, is that the disease incidence and prevalence is truly increasing. I think another part of it is maybe just leave it there. Sorry, I was like thinking too far ahead. I think there is a problem in the medical record when we look at things like code-based diagnoses, ICD codes for heart failure. I feel like in general, there's a problem that they're not very specific and that we might be capturing other things. And this idea of sort of multimorbidity is really challenging in terms of how specific can we be that someone was admitted, let's say, with a primary diagnosis of heart failure when they came in maybe with a touch of heart failure plus a touch of COPD exacerbation plus a pneumonia plus something else. I think that's a maybe larger issue.
Definitely. So while you're talking about obesity as one of these main risk factors for HFpEF, could you review for us some of the other risk factors that kind of make that classic phenotype of a patient that you see with HFpEF?
Yeah. So what are the known risk factors for HFpEF? I would say they're the classic cardiovascular risk factors we think about for anybody, and that includes increasing age, the presence of hypertension, and ischemic heart disease. What's interesting is that these risk factors are really overlapping and shared between people who eventually develop HFpEF and those that develop HFrEF. We're beginning to understand that the propensity toward HFpEF is greater among people with obesity and metabolic dysfunction. And there was one really interesting study that looked at physical inactivity actually as a risk factor specifically for HFpEF rather than HFrEF in the future as well. So those were sort of the main risk factors I think of in terms of future HFpEF risk. One other thing that I've been really interested in some of the work together with my collaborator, Dr. Emily Lau at MGH, has been this clinical difference that we know of where the prevalence of HFpEF is much greater among women compared with men. And she actually led a really interesting study showing that there are probably sex-specific factors, including a history of infertility that specifically predispose women to development of HFpEF over HFrEF. We don't really know what the underlying mechanisms are, but I think our understanding of sort of sex-specific factors is evolving as well.
All right. So I think this is backtracking a little bit, but I do want to go back and talk a little bit more about the pathogenesis of HFpEF as we're talking about these risk factors. So on like a more academic level, I guess, like what is it really that's causing this?
So the pathogenesis of HFpEF is really complex. I'm not sure anybody fully understands what happens. We used to think of HFpEF really as a disease related to hypertension and hypertensive LV remodeling that leads to LV stiffness. And I think this has really shifted more recently to this idea that HFpEF it happens in multi-morbid patients with central contributions from obesity and cardiometabolic disease. We think that those sort of predisposing factors probably incite systemic inflammation that then leads to endothelial dysfunction and altered myocardial energetics and abnormalities in skeletal muscle. And so it's a lot more complicated, I think, than we initially appreciated.
Great, thank you. I just wanted that good overview of like what it is we're really talking about. So sorry to jump back over there. One other thing that you mentioned earlier on when we were talking that I want to touch on too is that there are some scoring systems. You mentioned it when we were talking about the echo findings for patients. So can you talk about what scoring systems are out there and then which ones you clinically use when you suspect HFpEF?
That's a great question. There are two diagnostic scoring algorithms that have been developed in recent years. One is called the H2FpEF score that was developed at Mayo. And the second is called the HFpEF score, which came out of the European Society of Cardiology. The idea of both of these scores is that they incorporate comorbid conditions plus natriuretic peptides plus echo findings to kind of risk stratify people. And if you have a low risk score, you effectively rule out HFpEF. If you have a high risk score, you effectively rule it in. And if you're intermediate, those are the people where we may want to consider pursuing advanced testing. So those are the two scores. I would say that there's some potential for misclassification with these scores. And so we just have to be cautious. For example, the H2FpEF score was developed in the Mayo Clinic where people get referred if there's a question for HFpEF. And so the pretest probability walking in the door of somebody having HFpEF was something like 60% or greater. And so as we apply these scores more broadly in the primary care setting or other places where that pretest probability might be very different, we just have to be really careful about potential misclassification. I do think, the risk scores may be helpful, again, when the diagnosis isn't clear based on your first-tier testing. So your first-tier testing, I would say, is your clinical exam, your history, natriuretic peptides, and echo. If after that the diagnosis is still not clear, I think potentially getting some sense from these diagnostic scores of risk stratification can be helpful. And then again, in the intermediate scores or where the diagnosis is still not clear, I think considering some advanced testing that we already talked about, I think is indicated.
So, yeah, I'll be honest, in the hospital, I really haven't seen these scores being used that much. So could you give me an example of a patient where using this score would be helpful?
Yeah, I think probably the patient where this would most apply to is somebody where they don't have rest congestion, right? Because if they have rest congestion that you can pick up based on your physical exam and your history, they have the syndrome of heart failure and you're done. So the patients that I find most tricky to diagnose are people where at rest they seem to have normal filling pressures. You might cath them and their wedge pressure is normal at rest. And it's really with exercise provocation that that wedge pressure, the filling pressures, rise in a much steeper fashion and cause pretty severe dyspnea or exercise intolerance. Those are the patients where I think the diagnostic scores may be useful. If the risk is intermediate, then again, we have more of an argument to pursue some of these advanced diagnostic tests. Having said that, from a clinical perspective, I agree with you. I rarely use these diagnostic tests, mostly because we already sort of know all of the different components, and clinically, we're already looking at them. So, for example, in the HFpEF score, you're getting points for having hypertension, for having obesity, for having evidence of pulmonary hypertension on your echo, for having diastolic dysfunction on your echo. We're already sort of looking at all of the different components and getting a sense. So, in some way, we're probably, as clinicians, kind of internally calculating and weighing all of the different components already.
And to touch back on those HFpEF masqueraders that we've brought up a few times, you mentioned, are these scores helpful, do you think, in trying to parse out if this is HFpEF versus like a COPD caused dyspnea or something else?
Good question. I think of these scores as really helping with HFpEF diagnosis, but the sort of idea that we have to be careful and pursue other diagnostic testing in patients who might have HFpEF masqueraders, I think of as almost very separate. So the diagnostic workup for HFpEF masqueraders might take you down a completely different route. But if you ruled out HFpEF masqueraders and you're stuck with someone who has dyspnea and suspected HFpEF and you're not sure what to do, sometimes these diagnostic scores can be helpful in sort of risk stratifying people and figuring out, do we actually sort of consider something invasive like a level 3 CPET or a right heart cath inside?
Right. One clarification for me, this term that we've been using, HFpEF masqueraders, is this a commonly used term or is this something that we are all just using right now?
Great question. I think we've sort of more recently referred to this as HFpEF masqueraders. I sometimes also call them secondary causes of HFpEF that you want to rule out. And so I think the terminology hasn't been entirely clear. I do think there are two sort of scientific statements that were recently published in JACC that I can forward to you. And there we've really sort of tried to consolidate the terminology around HFpEF masqueraders to try to make it a little bit easier to understand conceptually. This is a separate disease process from sort of HFpEF in general.
Yeah, I like the term a lot. I'm finding it very helpful in separating these things. All right. Well, I do want to take a little bit of a turn here because I want to make sure that we have time to talk about treatments for HFpEF. It's something we addressed early on that one of the most important reasons for actually defining this diagnosis is in terms of treatments. So can you talk about what available treatments we have for HFpEF?
Absolutely. So the landscape of treatment for HFpEF has evolved greatly over the last couple of years. I think central remains sort of addressing and managing comorbidities. So that should be something that we obviously do in everyone, but I think becomes even more important in patients with HFpEF again, because often they're presenting with multimorbid conditions. And so really making sure we're treating their hypertension, their coronary disease, we've optimized their diabetes treatment, we're thinking about obesity. So all of those things are really important. And then that aside, we're sort of really looking at evolving treatment with what I call GDMT or guideline-directed medical therapy. What are the components of that? Currently, I would say there have been two pivotal trials that have really put SGLT2 inhibitors on the map as first line for anybody with HFpEF. Those two trials were EMPEROR Preserved and DELIVER, and they looked at treatment with either empagliflozin or dapagliflozin. Currently in the American Heart Association, American College of Cardiology guidelines, SGLT2 inhibitors have a class 2A indication. But recently, actually, the European Society of Cardiology moved these medications to a class 1 indication for patients with HFpEF. And I suspect the US guidelines will follow as well. So I would really say SGLT2 inhibitors should be broadly considered in patients with HFpEF. The other medication classes, there are two. The first is angiotensin receptor neprilysin inhibitors, or ARNI. The trial that looked at the use of these agents is called PARAGON-HF. The overall trial was neutral, but subgroup analyses showed some potential benefit in people with what they called below normal EF, and interestingly also benefit among women compared with men. So currently, ARNI use deserves a class 2B indication in the US guidelines. And I would say that we're using them mostly in people who have persistent symptoms on an SGLT2 inhibitor who also have evidence of hypertension, and in particular in people with below normal EF, or in this awkward category of heart failure with mid-range EF. And then the last class of medications are mineralocorticoid receptor antagonists. Spironolactone specifically was studied in a trial called TopCat. The trial, again, was neutral, but had really interesting geographic variation in treatment effects, until currently also is listed as a class 2B indication. And then lastly, we know that certainly loop diuretics for treatment of congestion is sort of the one class 1 indication in the US guidelines right now. So in terms of a general approach, I would say I typically consider SGLT2 inhibitors broadly in everyone with HFpEF. When there's congestion present, I actually really like potentially considering upfront mineralocorticoid receptor antagonists because they can treat some of the congestion and may minimize your use of the loop diuretic. But if people still have congestion, then of course we're using loop diuretics. And then in the setting of persistent symptoms with blood pressure room, I would consider ARNI. So those are sort of the medical therapies that we have to date. There's a lot of excitement around an evolving role of GLP-1 receptor agonists. There were some promising data recently published and presented with a trial called STEP-HFpEF that showed that GLP-1 receptor agonists in patients with HFpEF resulted in a sustained weight loss, but also really remarkable improvements in quality of life and also 6-minute walk distance. We don't have trials powered on outcomes just yet, but I think this will be a quickly evolving landscape, I would say.
Well, we covered a lot of material. So just to recap, it sounds like first, we're going to make sure that we're appropriately treating all of the risk factors that are contributing to their HFpEF. And then our mainstay of treatment is our SGLT2 inhibitor. After that, plus or minus MRAs, ACEs, and ARBs, and then diuretics for symptom relief. And in the hospital, we hear all the time not to use beta blockers in patients with HFpEF. Can you walk us through that logic?
That's a great question. So why are we concerned about beta blocker use in patients with HFpEF? I would say if the patient has another indication for beta blocker use, they have coronary disease and just had a myocardial infarction, they have atrial fibrillation with difficult to control heart rates, then of course we should be using beta blockers. But on the flip side, we know that chronotropic incompetence is a huge problem and actually can lead to really decrement in functional status among patients with HFpEF. And so often when there's not another obvious indication for a beta blocker, I will actually try to down titrate beta blockers or even stop them altogether in patients with HFpEF to see if that helps with respect to exercise intolerance.
Great. Okay, that's really helpful. One other question that I have about treatments is a lot of what we've talked about makes a lot of sense in the outpatient setting. But when we're talking about really sick patients with HFpEF, for instance, in the CCU, they often are hypotensive, and we're really careful about giving fluids to our patients with HFrEF. But do we have to be quite so careful in our patients with HFpEF?
That's a great question. And I don't know that I can give you a blanket answer to that. I would say that this has to be individualized. If someone is hypotensive and clearly in hypovolemic shock, they're bleeding, of course we have to volume resuscitate that person, irrespective of whether they have HFpEF or not. Or if they have distributive shock, right? I think IV fluids are clearly the right answer. I do think that patients with HFpEF, when you think about and go back to medical school and think about the left ventricle operating within a pressure volume loop, The end-diastolic pressure-volume relationship in patients with HFpEF that sort of moves you up and down in terms of changes in preload, that curve is much steeper in patients with HFpEF compared with someone, for example, with a dilated cardiomyopathy, where that end-diastolic pressure-volume relationship is much flatter. What that means is that for every increment in volume, the LVEDP rises more rapidly and falls more rapidly in patients with HFpEF. And so often I find that they're more sensitive to big shifts in preload, either increasing or decreasing. And so typically I am a bit more cautious in patients with small stiff ventricles. You can start with a smaller bolus and just monitor more frequently. But I do think in some situations, of course, IV fluids are indicated. We just have to probably be a little bit more cautious.
I love that. Can you give me an example of it? Two different patients with two different echoes, and how did you look at the level of stiffness and smallness? And you're like, oh, okay, we can do 500 cc's here or a liter here versus maybe be a bit more ginger.
That's a great question. Again, I don't know that I can give a blanket example, but one thing that I actually always encourage residents to look at when they look at echo reports is one measurement called the left ventricular end diastolic dimension, LVEDD, because that alone can tell you a lot about someone's sort of hemodynamics and both sensitivity to shifts in preload and sensitivity to shifts in afterload. And so if someone has a really large LVEDD and their ventricle is really dilated, both their end systolic pressure volume relationship and their end diastolic pressure volume relationship are flatter. And so those are individuals where often big swings in preload may not necessarily result in big changes in LVEDP. So often we can be more aggressive with IV diuresis, maybe be less cautious with IV fluid resuscitation, and they often respond beautifully to afterload reduction by increasing their stroke volume. So those are people with really high LV and diastolic dimensions because they have big hearts. People with small, stiff hearts, like our patients with HFpEF, are the opposite. So small shifts in preload, if you over-diurese them a little bit, they can very quickly become hypotensive and go into renal failure. If they're just a little wet, they can often feel really short of breath and their wedge pressure can go through the roof. And so I sort of think of them as almost having like a very narrow therapeutic window of where their volume status is perfect. And similarly, changes in afterload can really shift them very quickly. And so oftentimes they become quickly very hypotensive to afterload reduction without much change in their stroke volume. So I think one potential takeaway is that the LV and diastolic dimension can be helpful in trying to get some sense of how sensitive someone might be to shifting.
I love that. I'm just eating it all up. I would love if there's some specific like numbers or cutoff because I'm like, okay, great, I'm going to look at it, but I think I won't know what to do with it. But that leads to my next question, which maybe you can incorporate, which is we are so freaking hand wavy about like, maybe this person's like a torsemide 40 outpatient. Oh, maybe it's a 20. And you do this all the time in clinic. How do you decide what volume maintenance this human with this stiff ventricle needs?
That is a really great question. And I think a lot of sort of picking a diuretic dose is unfortunately still trial and error. I think, of course, people with, concomitant chronic kidney disease might have higher diuretic requirements. In general, if someone is loop diuretic naive, I start small and we just have to see how it goes, right? So Lasix 20, 40. In somebody where they're becoming more diuretic resistant, or you're worried about some component of tricuspid regurgitation or right-sided heart failure, that's a big component of their presentation where they might have trouble absorbing medications. We often sort of anecdotally say torsemide has greater oral bioavailability, and so they might do better with torsemide. So in the setting of severe TR or right-sided symptoms, often we reach for torsemide. Otherwise, if someone is loop diuretic naive, I would say start with furosemide or Lasix, low doses, and see how it goes. But I think, unfortunately, a big part of it is still trial and error and monitoring the patient as they sort of diurese.
Great. And Jen, you mentioned Emily before, and we're so excited to talk to her as well. But while we're talking about treatments, I would love to get your input. Is there any differences you think about for treatments in men and women with HFpEF, or is this all the same right now?
That's a great question. Do we treat men and women differently who have HFpEF? Right now, I would argue that we should be really approaching treatment very similarly among both men and women with HFpEF. There is some data, again, from the PARAGON-HF trial that women potentially derive greater benefit from treatment with ARNI compared with men. There was a really interesting post-hoc analysis that actually pooled ARNI trials across the LVEF spectrum. And it turns out that there is a treatment by LVEF interaction, such that the main benefit for ARNI use is in lower EF, and that benefit kind of goes away in higher EF. And it turns out it goes away in women at higher EF compared with men. So you lose the benefit at lower EF in men, and you derive more benefit until a higher cut point in women. Now, whether that should directly translate to potentially greater use of ARNI in women compared with men, I don't know. It's not in the guidelines as we speak. There was this JACC sort of clinical statement that was put out where the authors did differentiate potential use of ARNI among women versus men. And I thought that was sort of a really interesting statement to make. I think in my practice, I have been sort of doing ARNI irrespective of sex, really mostly guided by the presence of symptoms. And again, sort of thinking about potential LVEF interaction.
That was amazing.